Hi, this is Elliot Fishman, and welcome to the April 2017 CTisus quiz. We have 10 terrific cases for you, and so without further ado, let's get started. This is an interesting case, 60-ish-year-old female. You can see I gave you two sets of images, two 3Ds. One shows you a lytic lesion with irregularity of the cortex and medulla in the mid-humerus, as well as a lesion in the proximal left humerus. And then you see multiple lesions involving the ribs in a 3D view. So I gave you four choices. This isn't osteoporosis, though the patient probably is osteoporotic. It's not fibrous dysplasia. There's no expansile changes. This is more of an infiltrative process. Could it be renal cell carcinoma? Renal cell can give you lytic metastasis. Often there's expansile changes in bone, and often there's associated soft tissue masses. And when it's due to clear cell renal cell carcinoma, it's often vascular. When you see, however, these many lesions, particularly that look of infiltration of essentially all the ribs, you better be thinking about myeloma. And myeloma, indeed, was the correct answer. This patient has abdominal pain. I asked for the most likely diagnosis. This case has a terrific finding. When you look at the patient's small bowel, it's thickened. But what you really see beyond this is the thickening and the prominence of the vasa recta, and that appearance is called the comb sign. You look at all those little vessels, kind of looks like a comb that I have in my back pocket. The comb sign is associated with Crohn's disease. It's not ischemic colitis or enteritis. It's not with lymphoma. Carcinoid tumor gives you thickening of the vessels and a desmoplastic reaction, but the comb sign, all the way with C, Crohn's disease, is the correct answer. This patient has pelvic pain, and when you look, you can see on these two images that the patient has a destructive lesion involving the sacrum. What you also can tell about the lesion is that it's very vascular. So myeloma can infiltrate the sacrum, but it would not be vascular. Lymphoma can infiltrate the sacrum. This is a good location, presacral mass, but again, typically is not vascular. Chordoma would be a consideration. This would be a great location for chordomas. Chordomas are destructive, large masses, great location, and that's a possibility. The other possibility is metastatic renal cell carcinoma, particularly clear cell renal cell carcinoma, very vascular, and in fact, that's what this was. Now, if you put down chordoma, I have to admit I would give you partial credit. Another thing that you can see in this region would be recurrent colon cancer, and it involves the sacrum as well. But this was metastatic renal cell carcinoma. Patient had a large left renal mass. This patient had hematuria, and what's the most likely diagnosis? When you look at the axial images, you see a very bright vascular lesion or vascular process in the mid portion of the kidney. And then when you look at the MIP, you very nicely see the arterial and venous structures. It's a very fast filling. Now, it's true you can get fast or flush filling when you have a very vascular renal cell carcinoma, but when you look at the images here, it's not a mass. Kidney function's okay. It's not metastatic or transitional or renal cell. This was an AV fistula due to prior trauma. Many of the AV fistula we see are incidental findings, and they're not due to any specific cause, but this patient did have trauma in the past, but a very nice AV fistula that was eventually embolized. This patient's 70 years old, and I wanted the best diagnosis. Well, you can see there are lesions throughout the lumbar spine and lower thoracic spine, and also in the sacrum. The vertebral bodies are losing their height. They're markedly osteopenic. What could this be? Could it be osteoporosis? Well, severe osteoporosis, I guess I couldn't say it wasn't the case, though that wedging thing really bothers me, though you have collapsed vertebral bodies in osteoporosis. Lymphoma can involve the spine, but usually it's more sclerotic. You don't get this marked osteopenia. And chronic renal disease is a thought because that will give you involvement, but also it will involve the entire vertebral body and pedicles and the like. But it's a thought. What this was, however, was myeloma. Myeloma can involve multiple bones, multiple vertebral bodies, markedly osteopenic, loss of height, bulging of the discs into the vertebral bodies. So a very nice example of myeloma. Again, you could think of the other possibilities, but when so many vertebral bodies are involved, I'm thinking myeloma, though again, chronic renal disease can involve multiple vertebral bodies as well, but just a very nice example. This patient had right upper quadrant pain, and when you look hard, the first thing you see is the patient's right adrenal is enlarged. It's also of high CT attenuation. There's also minimal fluid around it. And without much thinking, this is adrenal hemorrhage. Now, adrenal hemorrhage on the right side can be due to trauma, but no history of trauma, and I don't see liver injury or renal injury. It could be due to tumor, like a MET or a primary tumor can potentially bleed, but this is really the entire gland that I don't see a mass beyond the bleed. And this patient, when we got more history, was on Coumadin, and this was adrenal hemorrhage. But it's a classic appearance, oval, high density. I threw in acute hepatitis in case you were being high risk in trying to come up with an answer. This is an interesting case, and I'm showing it to you a little bit atypically because normally you have the axials, dual phase, you have coronals and sagittals. Here I'm only giving you the MIP image. And what I'm showing you on the axial MIP is the lesion has multiple septations and is vascular, and from the coronal MIP you see that the hepatic artery is stretched around the lesion. IPMNs are cystic, they don't have all of that enhancement internally. SPEN tumors can have this, but often have calcification 70% of the time, but also the enhancement's irregular. And neuroendocrine tumors have lots of vascularity, but they would involve the vessel, and the vessels would be distorted. Serous cystadenomas can be large. They have vascularity, that Swiss cheese type appearance with vascularity, and then the vessels tend to be stretched. So in this case, beautiful stretching of the hepatic artery, and this was a serous cystadenoma. Just a really nice example. Now, this 50-ish-year-old patient had weight loss and GI bleed. So we're looking for a tumor, and you do visualize a tumor involving the fourth portion of the duodenum, and there's a mass associated with this. And when you look at the coronal volume rendered images, you can see multiple collaterals because the SMV is occluded. So what could this be? It could be a duodenal adenocarcinoma, but those usually aren't so vascular. And maybe the soft tissue mass next to it is nodes, but the vascularity and the vessel occlusion bothers me. Duodenal lymphoma should be bulkier. Pancreatic adenocarcinoma secondarily involving the duodenum. That's always a thought, but it's too vascular for that. So this was a duodenal carcinoid tumors. This was a fairly large tumor. Not only was the tumor in the bowel, but there were nodes present, the classic mass in the mesentery. You can see the vascular involvement of the SMV. That's very common in patients with carcinoid tumor with desmoplastic reaction. So a very nice example. And carcinoids are not uncommon in the duodenum. They can be solitary polypoid lesions, or as in this case, can be infiltrating. This patient had abdominal pain. Now, when you look at these images, you might consider, could this be a pancreatic tumor? We show you lots of pancreatic lesions, but if you look hard, you can see it's pushing against the pancreas, but not arising from the pancreas, and obviously you only have two images. What you really are looking at is a mass in the left adrenal. It's large, and it has prominent neovascularity. Now, lymphoma can occur, usually it's bilateral, but could occur, but it's not vascular. Adrenal hemorrhage typically isn't vascular, but maybe you had a vascular mass that bled, less likely. Pheochromocytoma can be large, can be vascular, but often is more vascular than this. This has some neovascularity or prominent vascularity perhaps, but pheo, not that big a fan. On the other hand, adrenal carcinoma, large, solid mass, 10 centimeters, some vascularity, neovascularity seen. Adrenal carcinoma is indeed the correct answer. This case is sort of a simple case. I have a bunch of beautiful images that you'll see on CTisus, but I just wanted to show you this example of a large vascular pancreatic mass with multiple vascular metastases. Okay, well, what could it be? Well, it could be metastatic renal cell carcinoma of the pancreas and liver, but of course that usually occurs 10 years after a renal cell carcinoma is diagnosed. The patient has both kidneys and they look pretty good, so it's probably not going to be that. SPEN tumors can have some vascularity, but not to this extent, and the liver mets are never so vascular. Look at the 3D volume rendering with texture mapping, how you see all of the lesions. Adenocarcinoma, nah, never so vascular. So we're left with the logical answer, a primary neuroendocrine tumor of the pancreas with multiple vascular metastasis to the liver. So that's it. 10 great cases. Hope you got them all right. More importantly, I hope you learned something. We're here every day, every hour, every minute on CTisus. So hope to see you there. Be good. Bye.